Recording in progress.
Welcome to week 3. Today's session is going to be about connecting concepts that on their own can feel kind of like really separate. Remember that we are talking a lot about medications, fluids, diagnostics, and safety. What I want you to start seeing is how all of these pieces work together in real patient care. They're not isolated topics, but as part of one system. Okay. Now, this is especially important as we get closer to midterms that are in just 2 weeks. And at this point in the module, we are kind of understanding the relationships, how fluids after diagnostics work, how medications influence patients' response, and how all that ties back to patient safety. Midterm questions often ask you to kind of like interpret different situations as well as recall facts. So you're kind of doing both. Today it's going to be about helping you see those connections just a little bit more clearly. Now, keep in mind, I want you to be thinking what important is what it tells you about patient safety. Okay. Again, it all comes back to patient safety. But we can't start without our quote of the day, quote of the week. Our greatest weakness lies in giving up. The most certain way to succeed is always try just one more time. That's by Thomas Edison. In healthcare, especially in surgery, okay? This idea shows up in a very specific way. Trying one more time doesn't mean kind of guessing, rushing, or kind of pushing forward when something doesn't feel right. It means verifying, it means pausing to double check information, confirm details, and make sure that we are about to do something safe. In pharmacology, this mindset is so important. Before administering medications, patient safety is going to depend on us trusting but verifying, right? Right patient, right medication, right dose, right route, right time. That extra moment of confirmation is often what prevents an actual error. Again, I know we haven't been to lab yet, but that's going to be here pretty quick. You haven't been to clinicals yet, but we're still starting that thinking now. Okay. It's like we're just pausing for that one more time. It's actually pretty professional. Okay. Because again, we are trusting, but we are verifying. Okay. So let's look at our goals for this evening. The foundation is what matters, but we're still focusing on how everything fits together. So we have the first step is the clinical question. We start by asking, what is the surgeon trying to see, correct, or manage? That's going to help us understand why diagnostics or medications are being used in the first place. Next is the agent and rationale. Okay. Instead of going through, we ask ourselves this: why this medication? Why this particular fluid? What problem is being addressed? Now, this is going to be really important because let's say you're getting a knee arthroscopy. The medications that you get in that knee scope are going to be different from the meds you get in the appy, that are going to be different from the meds that you're giving to your surgeon for a cranie, that are going to be different from the meds you give for an open heart procedure. So that's why these questions are really important. We look at the systemic connection, okay, where nothing works in isolation. Medications affect fluids, fluids affect electrolytes, and all of that affects the entire patient. So that's why it's so important that we know what case are we dealing with? What are the patient's comorbidities? Why is the patient coming to us in the first place? Why do I have sterile saline for some cases, lactated ringers for others? All right. And then finally, there's the safety checks. This is where patient safety comes in. What are the risks? What needs to be verified? What should make us pause and kind of reassess what's going on? But this is how you're going to be tested, not just on what you know, but kind of like how you think. How are you connecting these dots? When you use a framework like this, you're less likely to kind of miss key details and more likely to make safe, informed decisions. So let's pause and use our framework for this particular checkpoint. Imagine, okay, it's module 4. Actually, let's go to module 5. You guys are already in clinics. It's module 5, okay? You're reviewing a patient chart during the pre-op huddle. That sometimes happens. The patient is scheduled for a cholecystectomy. The surgeon mentions, you know what, I may do a possible intraoperative cholangiogram. That tells us that contrast may be used. Okay, so we're taking out the gallbladder, but before we take out the gallbladder, the surgeon is thinking about placing contrast in. Okay, one of the first thing that stands out to us, because we're all in that room, is that the patient has an allergy to shellfish. So now we're thinking, what's going in this contrast, right? Like, yes, we're critically thinking. Now we're like, okay, what's happening? At this point, I want you to think about what question should immediately come to mind. We're looking, we have contrast. Patient has an allergy to shellfish. So we look first. We have the clinical question. What is the purpose of contrast and what are we trying to visualize? Now, I kind of mentioned we're taking out the gallbladder. Okay, so great question. The patient signed the consent. The patient can sign. So we're going to, I hate to say assume, right? But we're going to say that the patient did sign the consent. So usually with a cholecystectomy where we're taking out the gallbladder, the surgeon will say, with that, it'll say with possible cholangiogram. That way the patient knows that they may have contrast placed into them. So great point. Check mark. Consent is signed. Okay. So now, what is the purpose? What are we doing? What are we trying to see? Next, we look at the agent and the rationale. What substance might be used and why? Now, this is important because this patient has an allergy to shellfish. Okay. So that means that we're looking at what's going into the body. We have the systemic connection. How could this interact with the patient's history, including allergies? And then finally, we have the safety checkpoint. This is going to be that key moment. The presence of shellfish allergy doesn't mean that something will go wrong, but it does mean that we pause, we verify, and then we communicate. What matters here is recognizing a potential risk and understanding why it must be discussed with the surgeon and the anesthesia provider before the patient enters into the operating room. So in the chat, we look at which step of the framework are we in right now. So here's the clinical question for you guys. So in the chat, I want you to type if you think we're in the agent and rationale, systemic connection, or the safety checkpoint at this particular moment. Okay, so we know what the case is. Yes, we know what we're doing. Exactly. We're at the safety check. Okay, I want you to think about what information you want clarified before we start proceeding with this case. So we're still at that pre-op huddle, and we take it just one step further. This challenges us. Hold on, let me make sure. Okay. This challenges us to look at high levels. Okay. These agents, they help structures appear clear on imaging, but clarity always comes with responsibility. So it's a job, all right? Let's start with it. Radiopaque contrast media work by really increasing the contrast between structures. It allows certain anatomy to be visualized just a little bit more clear on imaging. What matters is understanding why contrast is used. We're taking out the gallbladder, right? So, what might they want to look at before that gallbladder is removed? We know that it improves visualization when standard imaging isn't enough. Yeah, so the question is that's why we sign consent forms, right? Yes. So, a surgeon is not going to perform any additional things unless a consent is done. So, most definitely. And you'll find yourself in certain cases where you'll get into a procedure. They're doing, let's say, an exploratory lab. So, they're just going to see what's wrong. If they notice something is wrong, but the patient's not consented for it, they're not going to do it unless it's, of course, life saving. And that's a whole nother realm. Okay. But yes, consent form is signed. So we're getting back to, and that's Debbie just put out a good point. It's about liability, 100%, 100%. So we get to the understanding why the contrast is being used. Okay. And I'm going to tie that in. Consent is signed for contrast. So we know that everything under liability, we are golding. So check mark. Okay. You'll notice that this slide talks about different types of contrast media. Some are ionic, some are non ionic, some have higher osmolarity, maybe more than others. The thing is, it's important to recognize the different agents carry different risk profiles. And that choice is not going to be something that's random. This brings us to the key risk here in this cholecystectomy: hypersensitivity reactions. Based on what we saw earlier with allergies, okay, this is where your safety checkpoint mindset comes back in. A reaction may be rare, but rare doesn't mean impossible. This is why allergies, patient's history, and the contrast use are discussed before imaging or even bringing that patient into the operating room. Our role is not going to be like, okay, we're going to go ahead and select this contrast agent, right? Or back there in anesthesia or the anesthesia provider managing whatever reaction. But it's to recognize when, you know what, we are using a contrast medium. We understand that it carries potential risk. And we also are aware and are communicating to whoever we need to communicate with. Maybe that is the nurse anesthetist or the anesthesiologist. Maybe it's the surgeon. Maybe it's our circulator. Okay. Awareness and communication are going to be our big contributions to patient safety. All right. Now, what detail on this slide would make you pause and verify information? So, just looking at the slide, guys, once you take a minute and type in what detail you would want to be like, wait a minute, I want to verify just a little bit more based on what you see. I got one for your role. And keep in mind, you guys, there's no wrong answers. This is just to kind of get you into the critical thinking. So I like that. You want to know what your role is going to be. What am I doing at the field? Patients on the table, right? The key risk. Key risk is another big one. Based on our pre-op check, a hypersensitive reaction is one, right? So we're looking at nephrotoxicity. We may have a urologist on standby just to make sure that nothing's coming out. Patient's going to have a Foley. They're going to be checking for the urine output, right? Looking at the color, making sure there's nothing crazy going on. Okay. Both of those, the key risk, your role, they're good. Looking for adverse reactions, that's another one, right? What other things could we be thinking about it? And I kind of like that. I think apply. This is why we do those huddles. Okay. Now, each operating room could be slightly different, but we're still going to be talking about each and every single patient. Okay. So let's look at a different scenario and compare it to what we just kind of talked about. Now, in this case, imagine a pelvic surgery where the surgeon needs to confirm uteral integrity. Okay. Instead of a radiographic imaging, the team uses a dye administered kind of like IV to observe urine output. And now they're checking for leaks. They may have had a bladder surgery or something where they want to make sure that that bladder is still intact. Right away, I want you to notice something important. This task does not require contrast medium. It uses a dye for direct visualization. So keep in mind, in the last challenge, right, contrast media was used to make structural visible on imaging. The goal there was to enhance radiographic visualization. Here, the goal is different. The dye allows the surgical team to directly observe whether urine is passing appropriately and whether there's any evidence of a leakage. Think about the route here, okay? The dye is given intravenously, travels through the bloodstream, is filtered by the kidneys, and then appears in the urine. The purpose isn't to create an image, it's to confirm function. Okay. So, really quick, I've only had one person mention that they could not have their camera on. So, if you are able to have your camera on, please make sure that it is so that I can see your amazing faces. Okay. I also see a hand raised. Um,
It was me.
okay.
I had sent the message regarding my internet. That's why I
Yes,
signed
you're
in
good.
late.
Okay,
So
you're golden. You're golden.
okay, okay, thank you.
And then, um, Miss Moody, your hand is raised.
Oh yes, I had a question regarding the dye.
Yes. Go ahead.
Is this the dye that they put in the IV intravenous when you do MRI? Like, for example, I did one for a CT scan a
Mhm.
couple of years ago. So I wanted to know, is that the same exact dye that goes through your your veins and it's like a warm sensation?
Yes. It's kind of
Okay.
the same depending on what you went for, right? Because I had one too, and
Okay.
it's like a warm sensation. They put you through the MRI and they
Yeah.
do a lot of different scans to really
So
get,
they can see the
yes,
actual image. Yeah, I remember.
yes,
Okay.
yes.
Thank you.
You are welcome and good question. Good point. Um, so here we're looking at dye versus contrast. Okay. The agent and rationale are different. The reason we're using contrast, we're still doing imaging, but it's live. A lot of times we are, and I don't want to scare you guys because you're not alone, but you're mixing that contrast at the sterile field and handing it up to the surgeon, and they're directly placing it where they need it. And then a C arm comes in real time and the image is seen. Okay. Usually looking at the cystic artery, cystic duct. All right. And the dye, it's going through your IV. Okay. Kind of the same concept. We look at how the systemic connection is also different. The safety considerations are different. Okay. Even though both scenarios involve substances introduced into the body, the risk, the expectations, and verification steps are not the same. Again, I don't want you guys to get stressed out because you're not alone. You're not like trying to figure out like a mad scientist. All right. We just have to be aware. We have to be able to recognize one, what agent is being used, understand its purpose. And if something doesn't seem right, we're that patient's advocate. They can't speak for themselves. So we're communicating. You're contributing to patient safety by really just understanding why something is being done, not by making decisions yourself. Okay. Now, I want you to just think about how confusing these two scenarios would feel without like a framework to guide your thinking. They're both interoperatively, right? But one's a contrast, one's a dye. One is to look to see a certain image clear. The other is to make sure that there's no leakage in the bladder. Again, they may have had a bladder surgery. This is why, even though we're learning a lot of different terms and medications, it's also about understanding the purpose, the route, and the risk. And I love that. Miss Jennifer said a lot of patients are allergic to certain dyes. So, in that instance, we have to think, what other options do we have? Great point. So, we look at how it all connects. Okay. We have integrated contrast plus fluids. We look at patient safety. We ask the surgeon, okay, we're doing a cholecystectomy. So we're going back to scenario one. We're doing a cholecystectomy. The surgeon asks you to prepare the contrast media. Again, do not stress. This most likely will happen. Okay. It has to be diluted with an equal part of sterile solution. So the good thing is a lot of times they'll say 50-50. So you're getting 50 cc's of contrast, 50 cc's of sterile saline or whatever. So let's say we'll make it smaller, right? So here we have a 30 cc. Oh, I went too fast. Sorry, guys. We have a 30 ml, 30 cc syringe. 15-15. We're going to pull up 15 mLs of contrast, 15 mLs of saline. And it's usually like that. Sometimes it's like a 60-40, but it's nothing like give me 20.5 and they don't do that. So it's usually 60-40, 50-50. Okay. So we're putting it together. Now, at this point, again, I'm not asking you to kind of figure out what supplies that's going to be on your field. Okay. You're going to have it. I want you to think about why certain choices matter. We look at what is the standard compatible diluent for this purpose and why it is that specific fluid. Why is it so important? Again, we're talking about patient safety, how these fluids, pharmacology all intersect with each other. So, first, the agent and the rationale is what we're going to look at first. The contrast is being used for imaging. That means whatever is mixed with cannot interfere with visualization or patient safety. Okay, that's the big thing. We look next at the systemic connection. The diluent becomes part of what is going into our patient's body. Its properties are also going to matter. Okay. This is why 0.9% normal saline is the standard choice. Hint, hint, you may see that somewhere. 0.9% normal saline is isotonic, it's compatible, and it does not interfere with imaging or disrupt cellular balance. I have seen many concepts on isotonic solutions. I've seen many questions on one of the most used isotonic solutions. Okay. Now, keep in mind, 0.9% sodium chloride is what we normally use. However, other fluids like D5W, sterile water may seem harmless, but they carry risk in this context. Yeah, we have those in the operating room as well. But 0.9% sodium chloride, this is the third time I've mentioned it, it's isotonic and is one of the most commonly used irrigants solutions that we use in the operating room. So let me break it down a little bit more. Okay. 0.9% sodium chloride is isotonic. Sterile water is hypotonic and can cause hemolysis, meaning the red blood cells can kind of just swell up and rupture. That risk is going to be inappropriate for this particular procedure. D5W changes tonicity once metabolized, and it can actually interfere with both imaging and cellular stability. This is why we don't choose fluids casually, right? Compatibility is also about safety, not convenience. So we may have just one bottle of 0.9% sodium chloride all the way down in a different room. And right in front of us, we have tons of LR, we have tons of sterile water, we have tons of D5W. However, in this particular situation, we need a runner to go and get that bottle. Does that make sense before we move on? Okay, I see Princess kind of shaking. Okay, perfect. Now, yes, your hand is up. I see you. Yes.
I have a question regarding the sodium chloride water. Is there
0.9%.
I
Okay.
is there uh non-sterile and sterile both, right?
We only use sterile. So,
Okay.
yeah, of course, yeah, they'll have non sterile, but in the operating room, you'll only see sterile saline, even when we're doing surgically clean cases, right? You see, I put that surgically clean cases, we're still going to grab the sterile. Just it's safer and it's just universal. But great question. And that also takes out the guesswork. Like, okay. Now, now we're starting to understand why certain choices are standard. We're recognizing when something doesn't seem right. And we're always communicating concerns like, I'm not really feeling this. I just checked the patient's chart. They may have this comorbidity. I noticed that we're giving this particular saline. And granted, you don't have to get in that depth. But when you guys are having the huddle, sometimes these conversations can happen. Okay. Again, I want you to think about how many risks are avoided simply by choosing the correct compatible fluid. So when you mean by saline, 0.9% sodium chloride, um, okay, I don't want to assume. So what do you mean by that? Can we use saline? So we normally will have, yeah. Is that what you mean? 0.9% chloride, right? That I want to make sure I have it before I. Okay. Because I was like, is that what you mean? Now, yes. Yep. There's certain terms. So in the operating room, we're not going to necessarily, and I'm glad you brought that up. In the operating room, you're not necessarily going to say 0.9% sodium chloride. We normally say, I need saline. And we kind of like, oh, okay. We will grab the 0.9%. Now, heparin's a different beast because of the different doses. So when you ask for heparin, a lot of times it's going to be dependent on your case. Like if you're doing a central line, you may have 1 to 1,000 and 1 to 100,000, depending on where we're at in the case. So for that one, you're going to definitely want to make sure you have the right dose. But not every case will necessarily need a heparin. But most of our cases, we will have saline. And I say most because there are, of course, exceptions to certain particular procedures. Okay, but you guys are all thinking on the right kind of the right track. Now, we look into zooming it in, okay? From systems and organs down to cellular level. Imagine a cervical cone biopsy where the surgeon needs to now clearly identify those margins. We're looking to find where we need to excise this tissue that doesn't look healthy or just looks a little bit different. So now we're talking about staining agents, a little bit different. So we talked about contrast, we talked about dye, but now we're going to stain. Right away, I want you to think about the purpose. The agent isn't being used to image structure or confirm function. Okay? We're trying to see highlights of abnormal cells. The chapter talks about Lugol solution in contacts with selective staining. Normal cells can take up iodine differently than dysplastic cells or cells that look just a little bit different. That's going to allow our surgeons to kind of visualize margins just a little bit more clearly so they don't miss something. What matters is how these solutions work chemically. It's understanding that why is this being used and what does it help reveal? So I'm hoping you guys are kind of picking up how these are connected, right? You have your contrast doing one thing, you have your dyes doing another, and now we're looking at stains. So this slide right here kind of reminds us that the back table contains two brown solutions. Okay, it's on our back table, Lugols and Monsuls, and that's not accidental. Each has a very specific function. What's important at this stage is recognizing that using the wrong solution or using them in the wrong order has clinical consequences. Again, it goes back to patient safety. This is where verification culture matters. Similar appearances does not mean similar purposes. And that's one thing I really want you guys to kind of um, pick up. Okay. You'll also notice acetic acid. And I see a question, I'm going to go grab it. So I didn't forget you. I see you. Um, we look at acetic acid, also used for staining. Sometimes it's chosen instead, particularly when laser is used for excision. Again, you'll notice the different tools, the different stains are selected based on intent, risk, and compatibility. It's really important for us if we see a patient that has a shellfish allergy and Lugol's oil is the stain of use, that patient is potentially could have an allergic reaction. So the surgeon may want to grab acetic acid instead. Or if we're doing a laser case to kind of get rid of certain tissues, and we notice that, oh, wait, hold on. This patient, again, has a allergy to iodine. We're going to make sure that we kind of look at that as well. And again, we can grab the acetic acid. So really quick, how is stains and dyes different? Now that is a really good question. Dyes themselves, they color a structure, okay? They may be temporary, reversible. They're going to be used to highlight or visualize tissues or cells. They do not always chemically bind to that particular structure. So that's really important. I want you to think dyes help you see, okay? Stains, on the other hand, actually chemically bind to specific components. They are sometimes a little bit more permanent because we've got to be able to grab that tissue, and you don't want to stain it or put something on it and it disappears and then you're like, oh my goodness, the margins are gone. So they're used to identify, differentiate, sometimes even kind of just classify different structures, like this is healthy cervix tissue in this particular instance on the slide. This is where the margins are slightly off. Okay. And you often rely on acidic versus kind of like just basic components. Stains help you identify, dyes help you see, stains help you identify. Okay. Again, dyes, now I can kind of see. Stains, now I can actually identify. Yes, stains will stay longer, which is really important, especially when you're trying to get rid of margins. Dyes, visibility, stains, specificity. I hope I said that right. Specificity. Okay, hold on. I see something else. We use a lot of lugs at my job when doing cold. Yes, that's usually the go-to, unless of course the patient has an allergy, and then a lot of times they'll go to acetic acid. Okay. Anything dyes, color, visibility. Yes. So again, dyes, visibility, stains, specificity. And I see a hand. Yes.
I don't know if you already answered it. I just didn't get that part. So if we when we use uh, the staining agent,
Mm-hmm.
will it stain the particular place where we want to see, or around it so it could highlight?
So, great question. Depending on what the stain is versus Lugol's versus acetic acid, it is going to stain the tissue that's abnormal. And that's really important because with the naked eye, especially with the cervix, with the naked eye, you may see tissue, but you're not going to see the whole thing. Depending on the dye, it'll change, usually lighter for acetic acid and darker for Lugol's oil. So the abnormal tissue will be highlighted. Depending on which one, it'll be highlighted, it'll stand out. So just depends on the type of dye, how it's going to be presented. But in both cases, it shows more, so you can kind of see every part that needs just a little bit more of an examination or needs to be pulled out. So for this example, like right in front of you, okay, you have your normal tissue. Your acetic acid, once it was placed, it stands out more. But even with the Lugol's oil, you'll notice how it still has a distinct difference between the healthier tissue. The entire cervix was put with either or oil, just so you guys know. So they don't just put the spot they think. They're going to place Lugol's solution or acetic acid on the entire area, and then they'll start to see those abnormalities kind of like stand out. Does that make more sense? The dye itself just determines what it's going to look like. But the stain itself. The stain itself is just going to determine, is it going to look lighter or is it going to look darker? But they both do the same. An excellent question. Okay. Now we're not done. Oh, I see another question. Yes, Miss Tiffany. Sorry, I did not mean to miss you. Sorry.
No, it's okay. I just have a question going back to the other solution kind of thing. So does it matter like what how do I say it? I forgot the question. Oh my God. I got nervous. I'm sorry.
No, it's okay. You're good. You're good. You can type it in if you remember it, and then we can come
Okay.
back. That way you don't have no pressure. No
I
pressure.
I think it was just like, does it depend on what the person has? Like what kind of like not disease, but something, whatever. Does it
Like the
matter
type
what
of
they have?
tissue.
Yes.
So, the go-to is Lugol's oil. Okay, that's
Okay.
normally what we do, especially for like GYN cervixes is usually Lugol's oil. But let's say the patient is going and they are allergic to iodine, then they're not going to use Lugol's oil. They're going to then use acetic acid. But you also see that if laser is involved, It's safer because it's more of a vinegar-y, so they'll use the Lugol's oil in that instance too. But Lugol's oil is kind of like the go-to.
Uh-huh.
And then just think of acetic acid, because you may have cases where they're like, wait, I'm using acetic acid. It's going to be the kind of like backup if that patient has something, or if, again, in this case, laser is going to be brought in.
Okay. I see. Thank you so much.
You're welcome. All right. Now we got to talk about homeostasis. Not hemostasis, but homeostasis. While diagnostic procedures are taking place, we still got to look at patient stability, often maintained through IV therapy. They're in the operating room. They're not in there drinking a bunch of water, right? So we're going to have them hooked up to the IV. Fluids aren't just something that's running, they're actively supporting homeostasis. At high levels, that IV fluid therapy has three main goals, okay? Supporting circulation, maintaining electrolyte balance, and preserving tissue perfusion. This is why we're recognizing different fluids, how they're being used, and what they're supporting during a particular procedure. Okay? Too much fluid, too little fluid can disrupt that balance. That's why terms like hyper and hypo, they actually do matter. They describe when the system is pushed too far one direction. Okay? Now, why is fluid? Why this fluid? Why not this one? So you see in front of you, again, we have normal saline, lactated ringers, D5W. Imagine a trauma patient arrives with signs of hypovolemia. The anesthesia provider is calling for fluids because they're trying to restore volume. At this point, I don't want you to be like, okay, let me grab the answer. I want you to think about the properties. What each fluid does once it enters into the body. You see your options. 0.9% sodium chloride, saline, LR, and D5W. How does that affect where the fluid goes? So here's the thing. In hypovolemia, the goal is to restore circulatory volume. That means the fluid needs to stay in kind of like the vascular spaces, not shift to the cells. This is why isotonic fluids like 0.9% sodium chloride or normal saline are appropriate here. Okay? Because we want the fluid to go to a certain spot. You'll notice that D5W and LR marked differently. D5W, it looks harmless, but once that dextrose is metabolized, it behaves as a hypotomic solution. That makes it inappropriate for restoring intravascular volume in this particular scenario. All right. Now, if the patient requires packed red blood cells, only normal saline is compatible for transfusion. Only normal saline. Other fluids can cause hemolysis where the blood cells will start to rupture. That's not a minor issue, that's a serious safety risk. This is one of those rules that, you know what, we just don't bend, and it's not like a guessing one, like we're not going to do it. Grab the saline, okay? Again, we're not selecting it, but it's important for us to kind of like have an idea like this could potentially happen. So let's talk about the operating room, okay? Imagine a TURP. This is a transurethral resection of the prostate. It's a urology case, okay? Now, for these, they're constantly irrigating that bladder because they're trying to maintain visibility. And you're going to notice in a lot of different services, you'll have constant flow of one or another. In ortho, we have constant fluid in the joints. Again, visualization. In general, we have constant CO2 expanding the belly, visualization. So here in urology, when we're talking about a TURP, constant fluid so we can see what's going on. Does that make sense? Okay. Now, at first glance, normal saline might seem like the safest choice. Haha. Because you know what? We use it all the time. But in this particular situation, it's actually the wrong choice. Normal saline conducts electricity. Think about what's in it. You have sodium chloride. In a closed space where the ESU, which is the Bovie pencil, is being used, or the electrical surgical unit is being used, a conductive fluid increases the risk of unintended electrical injury. Now, that is a serious safety concern. Now, let's look at sterile water. Sterile water is hypotonic. If absorbed in large amounts during a TURP, it can lead to hemolysis, red blood cells swelling and rupturing. This is also where TURP syndrome becomes a concern. Again, it's a known risk. Okay? So if saline is too conductive and sterile water is too hypotonic, what is left? So here's a different one. This is where or why solutions like glycine 1.5% or sorbitol, which is normally what we use, 3% are used. They are non-conductive and are formulated to reduce the risk of hemolysis when absorbed. The biggest thing here is why a fluid is safe, unsafe, or in a specific context. Now, I want you to think about this. I want you to think about how dangerous it would be to assume all clear fluids are interchangeable. Thinking about the two cases or the two scenarios we just went through. So, your midterms often aren't about whether you kind of like recognize one or another, but how well are you able to understand what category it belongs to, what it's used for, and what risks come with it? We have your contrast media. We're trying to visualize. We're looking at internal structures. We're using radiography. The method is kind of blocking x-rays, which is why these agents are radiopaque. The key risk is going to be associated here, like is there an allergic reaction? Are we worried about nephrotoxicity? We look at dyes, direct visualization, either topically or a lot of times through IV, like we mentioned. We're looking at the difference from contrast media, and so are the risks. There's different. Allergic reactions can occur, but they're generally less common. And then your staining agents. I like this slide because you have all three kind of like in the same space. We look at what are we trying to see. The method involves a chemical reaction with tissue. The key risks here include tissue irritation or misidentification if it's used incorrectly. Again, the midterm isn't pulling from random places, okay? It's going to be built on that progression. Week 1, we talked about pharmacokinetics, pharmacodynamics, how the body absorbs, distributes, metabolizes, excretes substances. In week 2, we talked about the 6 rights. Now we're bringing those ideas together. We're not adding complexity, we're just connecting different concepts. Now, on this midterm that's only in 2 weeks, you're going to be expected to apply, define. You may be given a scenario like a patient with renal failure or renal insufficiency, and they may ask you to think which category of an agent might be contraindicated and why. Not necessarily in those specific terms, but just being able to kind of think it through on those questions. Now, as you prepare for the midterm, I want you to try asking yourself, what category does this or that belong to before worrying about details? Now, we did have polls that I'm going to just go ahead and put up so you guys can kind of see. the different concepts that may be presented. For those of you that are watching, you're going to get the same opportunity to see these. For those of you that are here, not required to answer anything at all. I just want you to be able to see some of the questions that, different concepts that'll look closely to what may be presented this week. Also, looking ahead, we know that this week, dun dun dun, we have Respondus Lockdown Browser with Monitor. So I want you guys to take a moment this week to think about where you usually take online exams, okay? Does that space support like you being able to focus? Is there privacy? Is there minimal distraction? Make sure you do have your CBD ID. If you don't, for whatever reason, for this week only, your government ID is acceptable. But the big thing is it's only this week. Make sure if you can get it by next week, if you don't have it, that you have it, if that makes sense. Okay. Again, there are the 15 questions that I just have up for you guys. As I kind of wrap it up, I do want to go ahead and do this for you guys so you guys can kind of see everything. Again, those that are watching, you'll have the same opportunity to at least see the questions, okay? As you guys are going through them, use these as additional resources, okay? Now, I want to bring us back to the big picture. We're learning to think through different processes. We're taking the definitions, we're going back to the recall, the analysis, the application, and we're taking it to the next level. We're talking now about purposes, how they're used, what safety considerations come with them. We're focusing on understanding how diagnostic agents and dyes and staining agents really support visualization at different levels, from radiographic imaging to direct visualization to now the cellular level, where we're trying to distinguish healthy cells from abnormal cells. For your discussion this week, these are for those of you that are watching the playback. How does the application of staining agents such as Lugol solution and methylene blue contribute to identifying normal tissue during surgical procedures? What precautions should be taken when administering iodinated contrast media, so a contrast media with iodine, and why is it so important to check for hypersensitivities? And in what ways do procedures like cystoscopy and the use of indigo carmine enhance assessments of kidney function and urinary tract health? These are questions that are wanting you to explain and kind of think outside that box why these agents are used and what they help protect. So really quick, just okay, someone when will we get the ID? So for those of you that do not have it, please make sure to reach out to Mrs. Shrooms, the program director, and she'll kind of like direct you guys on like the next steps. She said she was gonna probably email everybody that doesn't have one, so kind of be on the lookout. Okay, I see it should have been emailed to you last week. There you go. I have the picture. Okay, so perfect. So check your emails, check your spam. It may have gone there because you would have gotten an email from her. If for some reason you did not, please make sure you reach out to her as soon as possible. Again, this week you're fine because you can use your just regular government ID, but you just want to make sure you have it. Um, that is a great question. Make sure you reach out to her because I don't have that information. The question is, do we have to print it? So, yeah. So, Miss Hopkins said his name is Johnny. He's really good with all of that to make sure that you have that ID because you're gonna need that moving forward. Okay. Miss Moody, I see your hand.
Yes, regarding the IDs, previous students that were taking classes, they emailed them to us, and
Okay.
we won't get those physically till we start labs.
Okay. So,
Yeah,
but you do have the email, right?
yeah,
Okay.
we did.
Thank you so much. So
You're
you
welcome.
guys, there you go. that's information that now I know I can kind of share. But thank you guys. And this is really what teamwork is about, you guys. We are in this together. Okay. Um, let's end with a quote. Our greatest weakness lies in giving up. The most certain way to succeed is always try just one more time. You guys got this. All right. If for some reason something does act crazy, y'all just let me know. What questions do you have for me?
Sorry, I think I missed something. So what about the IDs? What's going on next week again?
You need your ID for Respondus lockdown. So this week, your government ID is fine to take, to kind of show to make sure that you are who you are for your exams. And for us, we just have our quiz, but other programs have multiple things where they have to do it. So for us, it'll be our quiz, our midterms, and our final. Okay. After next week, you'll have to have your CBD ID. Just make sure you have it, so you can kind of show as you take that exam.
But is this on Zoom or are we going somewhere to do this?
You guys will be doing it on Zoom. So, yeah, you'll be doing it on Zoom. Or
Oh,
not Zoom, but like Respondus lockdown. So to have,
right.
yeah.
Oh, okay.
I was
I
like,
thought
not
we
on
were
Zoom.
going
Like, I
somewhere.
won't be like windy. But yeah, you'll have a Respondus, Respondus lockdown. Yeah.
Right, which is what we've been using before, right? The only
Yeah.
difference is now we have to have our cameras on, right?
Yes.
Oh,
Yes. Yes.
okay.
Yes. Yes. Yes.
I have a question.
Yes.
So for quizzes, are those like closed notes, like the
Yes.
weekly quizzes? Okay,
Weekly quizzes are closed notes. Yes. Yes. Yes.
thank you.
What if
You're
we're doing the
welcome.
math part and we need scratch paper?
Um, let me send a message on the math part for you guys.
Yeah, because I know for math, I know they had allowed us to do maybe scratch paper at least.
Okay. Yeah.
And
Let
I
me
think
get
that's
get
more
clarification so that we know for sure what we can do for the pharmaceutical math. So I'm gonna send her a message for the math part. And then as soon as she gives me a response back, she has a class tonight. So she'll probably kind of get back to me after her class, and then I can get that information, at least for the steps as to what you guys need to do when it comes to that part of the exam. Okay, so I'll send that to her. And that's a good point, good question. Anything else? Nothing. Okay. I know this was a longer live session, a lot of
I do have a
information.
question, Miss Teresa.
Yes,
Are you
yes,
going to
yes.
get more into the math part, like for the dosage?
So when it comes to the dosage, you don't necessarily like we're not calculating. I would need
Okay.
Yeah, we're not actually calculating anything crazy. It's going to be kind of like what you just saw in your exercises. And the mini session that is up kind of breaks down some stuff. Hopefully you guys are able to locate that. Hopefully it's working
Yeah.
properly. Yeah. So if it is not, let me know. The biggest thing is when you guys go through those concepts and you've read, let me know
Yeah.
specifics so I can kind of break
I
those
problem.
down. Yeah.
Okay.
Because that's
Cool.
going to be easy. Yeah, okay.
I'm
Sorry, I
gonna
didn't mean to cut
message
you off.
you actually this week because I had an issue with those.
Okay.
Like the diagrams, and I know specifically for like the big finals, we don't really do diagrams,
Yeah, you won't.
but I want to get to know more into the liters, the dosage, and
Mm-hmm.
like that
And that
to know
that's a
the
good
different tubes.
that's a good point. That's going to be one, and I know I hate saying this to kind of trust the process. A lot of the syringes, just so you guys know, I know we have a minute left. We tend to use the 10 cc syringe the most, lure lock, just so you guys know. Um, Sometimes we'll use a Toomey, but for the majority of your cases, unless you're doing peds, it'll be a 10 cc um regular lure lock syringe for the most of your cases. So if you see something kind of different, like a tuberculin syringe, again, we use those in peds a lot, but it's a different beast altogether. But just do me a favor and kind of like really break it down because, like, vaguely, I could go on forever. And that's not going to help you guys. So I really want to kind of hone in as to like what is making this concept a little bit more confusing than the other. And then you give me that information and I can kind of break it down for you guys. Just midterms. Pharmacology math was week what, 1? Yeah, week 1, and you may see 1 or 2, not as much, but yeah. Great questions. All right, guys, it is 7:15. I will be on office hours. I know I did see one person had a question that I will be staying, but I am not going to keep you guys any longer. This was a really good live session, you guys. Let's keep up this momentum. Continue to ask those questions, and I look forward to seeing everyone who can attend tomorrow's live session.